Hello and welcome. To our US colleagues, good morning. And to our Israeli colleagues, Yom Tov le'kulam. My name is David Kimball. I'm the Senior Vice President for Research at Rutgers University. Together with my colleague Dan Pierre from Tel Aviv University, we would like to welcome you to the inaugural Rutgers and Tel Aviv University Scientific Symposium. We are excited to be initiating this series of monthly symposia that will lay a groundwork for research and academic collaboration, as well as for face-to-face meetings in the near future. Today, we're going to begin with the topic that acutely affects all of us. We're featuring two speakers who will discuss research response and lessons from the COVID-19 pandemic. So for those of you who don't know as well, Rutgers is the State University of New Jersey with over 70,000 students. We have 7 campuses across the state, in addition to medical school sites in New Brunswick and in Newark. Rutgers is a Research One university with approximately $750 million in yearly research awards. And we're a member of the American Association of Universities and the most ethnically diverse university in the Big Ten Academic Alliance. At this point, I would like to turn the microphone over to Dan Pierre, who is the Vice President for Research and Development and the Director of the Spark Tel Aviv Center for Translational Medicine. Dan, would you please share with us the view from Tel Aviv?
Well, I wish I could, showing you the seashore here near us. Anyhow, Tel Aviv University is now Israel's largest and most comprehensive institution of higher learning, with over 30,000 students studying across 9 faculties, 29 schools, and about 100 different departments. Tel Aviv University, raised as a world-renowned university in mere 50 years, demonstrates power of vision and dedication. It's really an incredible place to be in terms of the potential innovation and translation, not only from the business side, but also from the, I would say, probably from the scientific standpoint, and the ability to translate our research into potential therapeutic novel modalities. So David, I'm back to you.
Thank you. Before we begin all the scientific presentations that we have today, I would like to introduce you to several esteemed guests who are joining us. The first one on the agenda is our governor, Phil Murphy, from the state of New Jersey. Phil Murphy is the 56th governor of the state of New Jersey and has served since January 2018. At Rutgers University, we worked very closely with the governor and his staff in scaling up the Rutgers PCR saliva test to manage the COVID pandemic nationwide. We are grateful for the governor's support, and we're thrilled to have him join us today. Governor?
Hey everybody, Governor Phil Murphy here. It is my honor to be a part of today's symposium. Today marks the beginning of an important collaboration between Rutgers University and Tel Aviv University, 2 of the finest academic institutions in the world. In recent years, during my many visits to Israel, I was privileged to meet the leadership of Tel Aviv University, including former President Joseph Klafter and current President Ariel Porat, to discuss a vision for the future. We agreed that collaborating on cutting-edge research happening on our campuses, both in New Brunswick and in Tel Aviv, could ignite a partnership with unlimited potential for both our citizens and, importantly, our economies. New Jersey has a long history of innovation. We were Silicon Valley before there was a Silicon Valley. And as we reclaim this legacy, we are paving the way globally for new industries and technologies that will change how we live and work for, importantly, the better. This is why I am so proud and eager to see this partnership between 2 top universities come to fruition. As we hear these timely presentations today, we are reminded that the research being done at these institutions is meeting the most pressing challenges of our time to confront this pandemic and bring us closer to overcoming the difficulties that lie ahead. And together, there is no limit to what we can achieve. So I want to thank the leadership at both Rutgers as well as Tel Aviv University, especially Presidents Holloway and Porat, for advancing this wonderful partnership, in addition to everyone involved in this symposium. I can't wait to see what comes next. And in the meantime, I wish you all the very best.
Thank you, Governor. I would like to introduce Israel Nitzan. Israel is Acting Consul General of the Israeli Consulate in New York City. Israel, welcome to the first Rutgers University Tel Aviv University Symposium. We are glad to have your support in this collaborative endeavor.
Thank you. Thank you very much, Dr. Kimball, and shalom and good morning. First of all, I thank you for inviting me to this important symposium. I want to thank you, Dr. Kimball and Dr. Per, for, as well as Governor Murphy and the presidents of and the leadership of the universities for initiating this important gathering of experts and scholars from Israel and from New Jersey for a discussion on ways to address one of the biggest challenges these days, COVID-19. COVID-19 is a challenge for all of us to the health and the well-being of our communities, but it is also an opportunity. It's an opportunity to join forces and to work together to find solutions to the needs of our communities. The state of Israel and the state of New Jersey enjoyed many similarities in their geographic size, the size of the population, but I think that we also share the same spirit of innovation and entrepreneurship, of excellence in academic research. Governor Murphy's visit to Israel gave an additional boost to our cooperation, and we thank him for his leadership and for making this relationship a priority. Since the outbreak of the pandemic, we've had a long list of bilateral dialogues on ways to address government to government the different aspects and challenges posed by COVID-19 and its effect on our communities. We can do much more, and I think that this, by working together, first of all, and this great opportunity today that is the first step of actually bringing Israeli and New Jersey scholars from top universities in Israel, Tel Aviv University, and in New Jersey, Rutgers University, to find ways to basically to make this world a better place. So I want to thank again the organizers, and I wish you all a fruitful and an interesting discussion. Thank you very much.
Israel, thank you so much for your support. As I mentioned earlier, we're especially honored to have the presidents of both Rutgers University and Tel Aviv University with us today. First, I would like to introduce the 21st president of Rutgers University, Jonathan Holloway. Dr. Holloway is an esteemed historian and educator who specializes in post-emancipation United States history and in African-American studies. He earned his bachelor's degree from Stanford University and his PhD from Yale, and then began his academic career at UC San Diego before rejoining the faculty at Yale, where he was appointed Dean of Yale College and Edmund S. Morgan Professor of African-American Studies, History, and American Studies. Before he moved to Rutgers this year, Dr. Holloway was provost at Northwestern University from 2017 through 2020. President Holloway joined Rutgers right in time in the middle of the COVID pandemic. So today's discussion is directly relevant to the challenge we're all tackling with him as he begins his tenure. I am pleased to welcome President Jonathan Holloway.
Thank you, David. And thanks to everybody for allowing me to spend a few moments with you today. The first time I met Governor Murphy and his senior team was back in January, a week before I would be introduced to the Rutgers community. And I met him on the literally 10-15 minutes after he completed the State of the State address. So I was hoping the speech was well received when he was meeting me for the first time. During that speech, he said, "As Rutgers goes, so goes New Jersey." He recognized in that phrase that Rutgers is a major driver of the state's economy. That same evening, as I heard those words from the governor I was about to meet, I also heard about the Hub, this exciting new innovation site 50 miles from New York City and Philadelphia that bring together academic leaders, entrepreneurs, government, all in service of the greater good. I see the Hub as a natural expression of Rutgers' strategic vision of building academic excellence through research and collaboration across sectors. When I heard about the hub, this is before COVID was found in the United States, before it affected us so grievously, I was looking forward to trips to Tel Aviv University to meet President Porat and his team in order to establish mutually beneficial collaborations between our institutions. Locally, I was looking forward to an active construction site, adding to New Brunswick's growing cityscape. As we all know, the global pandemic intervened, and while I'm not thrilled about any aspect of the pandemic, I am thrilled that we have found a way to move forward in the interim with this first symposium. Understandably, it has COVID's footprints all over it. There's no way around it in this world in which we're living. I'm heartened to know that this first symposium, though, will not be the last, far from it. In a few years' time, we will look back at this moment, I think, as a time when leading universities, businesses, and New Jersey government came together to forge overlapping partnerships that, through the pursuit of knowledge and a commitment to innovation, charted a new way forward, benefiting the state, national, and international economies. For me, when that day comes, it will be a realization of Governor Murphy's statement that as Rutgers goes, so goes New Jersey. This time, though, it will be as Rutgers and TAU go, so goes the world. Thank you for having me, and I hope today's symposium gets off to a wonderful start. David?
Thank you, Jonathan. We really relish your support. Let's turn the microphone now over to Dan Pierre to introduce the president of Tel Aviv University, Ariel Porat. Dan?
Thank you, David. I'm really honored and really great pleasure to introduce Ariel Porat, president of Tel Aviv University. Ariel Porat is the Allen Poor Professor of Law and the president of Tel Aviv University from 2019. He's a member of the Israel Academy of Sciences and the Emet Prize laureate. Between 2002 to 2006, he was the Dean of Tel Aviv University Faculty of Law. And from 2003 until his appointment as the president of the university, he was also an associate member of the Fisher-Neil Distinguished Visiting Professor of Law at the University of Chicago. In addition, he was a visiting professor at the universities of Berkeley, Columbia, New York, Stanford, Toronto, and Virginia. That means that you have to take him as well to your university at Rutgers. So it's my pleasure and honor to introduce Professor Porat.
Thank you, Danny. Governor Phil Murphy, President Jonathan Holloway, Israel Nitzan, Acting Israeli Consul General in New York, David Kimball, Senior Vice President for Research at Rutgers University, Dan Pe'er, Vice President for Research and Development at Tel Aviv University, dear friends and colleagues. About a year ago, just a few months after I entered office at Tel Aviv University's new president, Governor Murphy visited Israel and spent some time on the Tel Aviv University campus. He presented to Tel Aviv University's leadership a very ambitious and inspiring plan to establish a hub of entrepreneurship and innovation in New Jersey, in biomed and high-tech, and generously invited Tel Aviv University to be part of this initiative. He informed us that Rutgers University is also going to be part of the enterprise, and this was more than enough to convince me and my colleagues at Tel Aviv University that this is an opportunity that should not be missed. We enthusiastically accepted the governor's offer. A couple of months later, I talked with Rutgers University President Jonathan Holloway, then President-elect, and after a very friendly conversation, we agreed to start collaborations between our two universities even before the wonderful plan of Governor Murphy transpires into reality. Today's symposium is the first collaboration between Rutgers and Tel Aviv University, and I am confident that many others will follow. The emerging partnership between the two universities is promising because we share the same values and have similar characteristics and ambitions. On Rutgers' homepage, I found a sentence which I really liked very much. We are an academic, health, and research powerhouse and a university of opportunity. I believe Tel Aviv University is also a university of opportunity. And let me say just a few words about our top 3 strategic goals and how they make us such a great fit for a partnership with Rutgers and also with Governor Murphy's initiative. One goal is expanding the globalization of the university. Thousands of international students from all over the world study in various programs at Tel Aviv University every year. We intend to increase that number significantly in the next few years. But most importantly, we have various ongoing teaching and research collaborations with top universities abroad, mostly, but not only, American ones. For example, we have several ongoing joint programs with Northwestern University, where President Holloway served until recently as a provost. We are very pleased and proud to initiate such collaborations with Rutgers University, a top global university. The second strategic goal of Tel Aviv University is enhancing our multidisciplinary culture. Tel Aviv University is a comprehensive university. Almost any field one can think of is studied and investigated on our campus. We strive to leverage this characteristic to build more bridges among various fields, in particular between the core sciences and softer ones, such as social sciences and humanities. In the last year, we have established several new multidisciplinary centers, including ones for AI, for quantum science and technology, and for combating pandemics. A few other centers are under construction. One of them is a center for healthy aging, where biomedical sciences will make up the core, while other fields of knowledge will be integrated into this center as well. The third strategic goal of our university is to deepen this and strengthen our relations with the biomed and high-tech industry in both Israel and abroad. Israel is the startup nation. Tel Aviv is the center of the startup nation. And we at Tel Aviv University are at the center of the startup nation. Innovation and entrepreneurship are Tel Aviv University's middle name. The lion's share of innovations coming out of Israel are closely connected to our scientists and alumni. We are eager to maximize this strength of Tel Aviv University for the benefit of both the Israeli and global communities. Given these three strategic goals of our university, globalization, multidisciplinarity, and industry relations, one can easily understand why my colleagues and I are so excited to collaborate with Rutgers University and to be part of the New Jersey Governor's Initiative. I want to conclude by thanking Governor Murphy and President Holloway for establishing these promising relations. We are very much looking forward to working with you in the next years to come. Thank you.
Thank you very much. Finally, let me thank Governor Murphy, Consul General Israel Nitzan, President Holloway, and President Porat for joining us and sharing their thoughts with us today and providing leadership for this initiative. Now let's move into the scientific session. We have two speakers. They will be followed by a question and answer session, which will be led by Dan Pierre. Please submit your questions in the Q&A tab during the presentations so that we can address them at the end. Our first speaker is Dr. Brian Strom. Dr. Strom is the Chancellor of the Rutgers Biomedical and Health Sciences and Executive Vice President for Health Affairs at Rutgers University. He's responsible for the Academic Medical Center, which consists of 2 medical school sites and several professional schools. Brian is also a clinical epidemiologist, and he has literally written the book on pharmacoepidemiology. He's considered the founder of the field, a field which applies epidemiological methods to the study of drug use and drug effects. Dr. Strom came to Rutgers University 7 years ago following a distinguished career at the University of Pennsylvania. It is my pleasure to introduce my friend and colleague, Brian Strom, to discuss the COVID-19 pandemic and the state of New Jersey, one U.S. state's response at the epicenter of the outbreak. Brian.
Thank you, David. And can people, yeah, great, there's my slides. So it's a pleasure to meet all of you, and I could spend the next 5 hours talking about Rutgers Biomedical and Health Sciences, but will not. Instead, what I'll be talking about is the COVID-19 pandemic in the state of New Jersey, one U.S. state's response at the epicenter of the outbreak, which unfortunately we were in the spring. Next slide, please. Firstly, what is COVID-19? The virus is a strain of the species severe acute respiratory syndrome related coronavirus, SARS-CoV-2, related to the common cold or some of the causes of the common cold, SARS and the MERS viruses. Closely related genetically to coronaviruses in bats, it emerged in China's Wuhan province with the earliest infection, so-called patient zero, occurring in November of 2019. The R0 number is estimated at 1.4 to 3.9, meaning irrespective of any public health interventions, every case will lead to anywhere from 1.4 to 4 cases. So it is rapidly contagious, spreads very efficiently without any interventions. Next slide, please. To give you a sense of COVID-19 virulence and infectivity, this is a graph from the New York Times. If you look on the horizontal axis, it's the average number of people infected by each sick person. If you look at the vertical axis, it's the case fatality rate on a log scale. So as you can see in the big box there, the Wuhan coronavirus, as it was referred to at that point, was about as contagious as the common cold, a little bit more contagious than the flu, and with a case fatality rate which was less than but approached SARS, Spanish flu, polio, smallpox, et cetera. And so it was clear from the very beginning, this was February 2020, that this was going to be a bad pandemic. Next slide, please. COVID-19 is spread via respiratory droplets that are either airborne or on surfaces. We've learned since that, in fact, surfaces seem to be less important, but certainly respiratory droplets seem to be much more important, both droplets and aerosols. Infection occurs when you're within 6 feet of a contagious person and come in contact with droplets or touch a droplet contaminated surface and then touch your face, mouth, and eyes, or eyes. And then again, since then, we've learned about the importance of aerosols as well, goes beyond 6 feet and doesn't drop to the ground and surfaces nearly as fast. Symptoms appear 2 to 14 days after exposure. Common symptoms include fever, cough, shortness of breath. Some patients report loss of sense of smell and taste prior to their onset of symptoms. Next slide, please. Steps to control the spread, and this is specifically for COVID-19, but really reflects any respiratory infection. One level is containment, next level is mitigation. Containment is halting the spread of infection, and this is when infection is limited to concentrated localities. And the idea is to identify cases, quarantine them, and isolate them when there are small numbers of patients and their contacts. So you identify the people, you again, you put them in quarantine, you separately put their contacts in quarantine to keep them separate. Other mitigation attempts slows the spread of infection with travel restrictions, social distancing, expanding testing, shelter in place, the most restrictive. And the goal is really to bend the curve, reducing patient surges. When all of this fails, the net result is suppression. Next slide, please. And this is the goal of suppression. We went through this in the spring. Israel did as well, and Israel, I gather, is approaching this as again. We may soon need to be there again as well. The goal of this horizontal axis is time since first case, vertical axis is number of cases. The red bar, what you see, the red curve, is what would have happened without protective measures. And as you can see, it exceeds the health system capacity. That happened in Italy. It happened a little bit in New York. The goal of suppression is to flatten the curve. It doesn't necessarily decrease the number of cases. What it does is it spreads them out so you don't extend the health system capacity. Next slide. A recent poignant statement that I've just seen on the internet: we isolate now so when we gather again, no one is missing. That's the public health approach, and really unfortunately, still most of what we need to do with this epidemic. Next slide, please. So let me give you a sense quantitatively, and these are data from last week. So obviously it's changed worldwide. The dark red is showing where the most These are cumulative cases globally. And as you can see, obviously the eastern half of the United States is solid red. Next slide. Zeroing in on the US, the Northeast was hit most hard, including New Jersey and New York in the spring. Right now, we're beginning, this was a coastal disease. Right now in the US, it's becoming a center of the country disease. Instead, with the coasts are in somewhat better shape for now, at least. Next slide, please. This is daily trends in US COVID cases reported to the CDC. Again, these are data from November 5th. As you can see, we are now in the middle of what for New Jersey is the second wave surge, second wave. For the US is the third wave. And we have now already exceeded the number of cases that were in our second wave. And we expected it will dramatically increase over the next weeks and months. Next slide, please. So to give you a sense, again, as of November 5th, global and local, cumulative number of cases worldwide, 48 million. In the US, 9.5 million. In New Jersey, 245 million. New Jersey deaths, about 15,000. Just to give you a sense of ballpark, this is more deaths than in New Jersey than in all of New Jersey's wars put together, except for World War II. All the wars in the US has fought in history. There were more deaths in New Jersey in that 3-month window in the spring than all of that put together. Things had gotten so bad, we at Rutgers were asked for parking lot space for body bags because there wasn't enough space elsewhere for body bags. Current hospitalizations, you can see now exceed 1,000, currently on ventilators 85, 225 intensive care, and our rate of transmission is now back up to 1.27. So for every case that exists now, there is on average 25% more cases that emerge. Next slide. The demographics of this population are not quite the same as the general population of note. New Jersey's population is approaching 9 million, with 21% under 18, 16.6% over 65 years of age. This is the general New Jersey population, 54% white. As David was talking about early on, we are a very diverse state. People claim that we are the most diverse state in the country. I have trouble with that as an epidemiologist. I'm not sure how you quantify diversity, but to say that we're the most. But clearly, we are a small, very compact, very densely populated, very diverse state. Next slide, please. If you look at daily trends in New Jersey, you can see, again, we are now entering our second peak. We are nowhere close to where we were in the spring yet, but it's rapidly increasing. This is number of cases and what's happening to number of cases. Next slide, please. You look at new and cumulative cases, you can see the curve heading upward. Again, that's cumulative cases that's superimposed on the underlying curve, bar curve, showing that we're now early in our second surge. Next slide, please. If you look at hospitalizations, they lag typically cases by about 2 weeks. And you can see that on the left-hand side, hospitalizations in the spring, on the right-hand side, what's beginning to happen in hospitalizations now. As of last week at our principal teaching hospital in New Brunswick, the number of cases remained in the hospital. The number of cases remained about the same as over the summer when at the trough. In Newark, we had about twice as many cases as in the summer, but still much lower than it had been before. I gather there were a wave of cases that came in this weekend into the hospital. And again, there's a 2-week lag for hospitalizations and roughly another 2-week lag for deaths. Next slide, please. Here's the death data. You can see our peak in early April. We were having 500 deaths. The number of deaths has not yet picked up. So that's something we anticipate in the next few weeks. Next slide, please. You look at it by race and ethnicity and age and gender, however, you'll see that it is not equal across the state. If you look at cases, they are disproportionately in the elderly. This is cumulative so far. And if you look at at cases, again, they're disproportionately in the minority population. That's in contrast to flu, and it's contrast to which affects the young a lot as well. And it's in contrast as well to what's happening now. The first wave of disease was disproportionately in elderly, and in the and deaths especially were disproportionately in the elderly and people with underlying conditions. We're now in the second wave. We are seeing what the rest of the country has been seeing for the last couple of months, which is it's more young people, that is people in their 20s, partying, thinking they're invincible. But at least in the rest of the country, that's led by the universities, unfortunately, and then the universities then spread it to the rest of their environment as it moves to middle age and back into the elderly again. So we are now in New Jersey. We were very much on the vanguard in the spring, and we did a great job with support, direction from Governor Murphy, and cooperation of the public of getting control of that with lockdowns. We started at a lower level compared to the middle of the country, but we're rapidly increasing again now. Next slide, please. So just to give you a sense of the timeline in New Jersey, January 2020, it was clear to us from a health affairs point of view, looking at what was happening in China, that this was going to be a pandemic, and we began planning for the pandemic in January. February 28th, we activated our COVID-19 task force as part of our emergency operations plan. March 4th, the first New Jersey resident tested positive for COVID-19. March 9th, the governor declared a state of emergency for the state. March 10th, we announced cancellation of in-person classes and instruction transitioning to online learning. Again, you saw those deaths in March or April. Remember, our first case wasn't until early March. This was an incredibly rapid process. Next slide, please. March 23rd, the FDA approved emergency use of the first rapid COVID-19 point of care test, which was developed by Dr. David Alond at New Jersey Medical School in Newark, one of our medical schools. April 13th, the FDA granted emergency authorization for RUCDR's saliva test, the so-called Rutgers saliva test, developed by Jay Tishfield and Andy Brooks of Rutgers, New Brunswick, now used in many tens of thousands, probably close to 100,000 a day now across the US. April 24th, Rutgers began transition down from its emergency operations to recovery efforts. May 15th, Governor Murphy allowed elective surgery to resume. We had basically become, as a healthcare entity, we had done nothing but a COVID for all that time period. We issued a travel advisory quarantining against traveling to New Jersey from other states. Parenthetically, we've now reached the level of disease that we would qualify for our own quarantine put in place there. And then the return to Rutgers plan was submitted in mid-August to the New Jersey Office of Higher Education. So this has been an extremely rapid process, enormous stresses, enormous deaths, basically everything shut down healthcare-wise for months on end. And we are now have been on the other side of that as things got better over the summer. Next slide, please. We are extraordinarily, this is a sign from the New Jersey Turnpike. We are extraordinarily thankful to our healthcare workers from the bottom of our hearts. We have 1,000 physicians in Rutgers Health who, in partnership with our hospital partners at RWJ Barnabas Health, basically spent endless hours, day and night, for months on end. Ultimately, the US gave federal aid to hospitals that were hit hard by the pandemic. Hit hard was defined as, did you ever cumulatively treat 100 cases? We never went below 100 cases at any given time in each one of our hospitals for weeks and weeks and weeks on end. The severity of this and living through this was just absolutely horrendous. It could not have happened without our healthcare workers. We graduated medical students early, we graduated nurses early, we graduated pharmacists early to go out into the workforce. This was a true mobilization in a huge way. I am, however, happy to say that, to my knowledge, no one in New Jersey died due to lack of a hospital bed. No one in New Jersey died due to lack of a ICU bed and no one in New Jersey died due to lack of a ventilator. But we came very, very close. One of my colleagues, his brother is on the board at Tesla. Tesla manufactured extra ventilators for us because we were running out of ventilators. And then when their ventilators didn't fit into our connections, our engineering department mobilized 3D printing in order to manufacture the part needed to make the connection. We were continuously running out of PPEs to protect employees. This was really touch and go for months on end. Next slide, please. We're now on the other side, on the left-hand side, returning to Rutgers. This is from mid-August. The university returning. On the right-hand side, repopulating RBHS, my part of Rutgers. Again, beginning to return toward normal, at least temporarily. Next slide, please. The new normal. Key as part of this has been what we've called our 4 T's: targeting, testing, treating, and tracing. We enormously expanded the amount of testing that was done with the assistance of the Rutgers saliva test. But very much by design, we were not testing randomly. We were not testing indiscriminately. People don't realize that testing is not armor. The fact that you're negative today doesn't mean you're not going to be positive tomorrow. And part of what we found is when people got tested and they were negative, they would go out and do stupid things. So key to maintaining proper behavior was not to over-test, but to target the testing to people who are at high risk. The most important things were and remain the public health interventions: distancing, masks, washing hands. And the testing was intended for the people who couldn't do that, ideally, like people working in laboratories, for example, and all the COVID research we were doing. So we rolled out enormous amount of testing, but it was all targeted, partly because this is a disease, unfortunately, unlike flu or colds, that 40% of people are asymptomatic and another 40% are mildly symptomatic and pass the disease before they become symptomatic. So the only way to identify those people and to isolate them, to contain them, is in fact using testing. And then you test them and you have to trace their contacts and quarantine both of them. Next slide, please. So we rolled out the saliva test. We now have 6 of these testing centers. We will, within the next couple of weeks, have 9. Next slide, please. And testing was really key to keeping New Jersey open. We tested residents of Newark and New Brunswick, our clinical faculty and staff, hospital staff and family members. The Rutgers saliva test was also used in New Jersey developmental centers, our state prisons, Essex County jails, many, many other places. And now it is being deployed all throughout the rest of the country as well. Next slide, please. Our philosophy of testing was that it was to be informed by CDC and New Jersey Department of Health guidance, health system partner requirements, and our testing capacity and logistics, based on the ability to maintain physical distance while completing activities on campus. Also for people who work in learning in a patient care environment, people who are exposed to confirmed cases, people who had congregate living environments like residence halls, people living in our kids living in our dorms, were tested and are tested weekly, working and or learning in an environment where they may expose at-risk individuals like security people, and based on evolving science and public health data. Next slide, please. So as of October 31st, we had conducted 11,000 tests, and I'm very happy to say that the number of positives were very low. And right now we're testing about 5,000 a week. Next slide, please. This dashboard, and this shows you the data through October, is available on our web. We update it weekly. Public health authorities get worried when the proportion positivity, the right-hand column, gets above 5%, with the idea that it may start becoming exponential in passage when you do that. And as you can see, through that time window, we mostly were very low. Next slide, please. This gives you the pattern to be able to see it. And again, you see where the 5% line is across the middle. The state has now exceeded 6%. So we had 2 blips. We had one in August when our football team returned to campus. We tried to keep them in a bubble. They and their coaches lived in nothing but a hotel. They didn't mix with other people, and they lived by themselves. It worked for a few weeks until two of them decided to go home to see their girlfriends, and they came back and infected 15 other people. So we got control over that. And then in early October, the second blip was from the Labor Day holiday. In early September, the kids came back to campus, even though most teaching was still online. They went and party, and we had a second epidemic, a second blip in the positivity rate, with enormous cooperation from our student affairs people, from the Rutgers, with the Rutgers student government. As well, we were able to get control of that as well. So our positivity rate remains below 1%, where the state's positivity rate has now gone up to 6%, and so is in worrisome range. So the state is getting worse, but we so far at the university have maintained control by our targeted testing method. Next slide, please. We've also created the Community Contact Tracing Corps. Governor Murphy announced the creation of it on May 12th, partnering with our School of Public Health. We have now trained 2,000 people as tracers across the state to be able to assist the state government in following up. When there's a positive case, we then trace them. We can't put in place in the US the kind of controls that some of the Asian and other countries can in terms of population controls because of individual freedoms. But instead we can be very aggressive with tracers. Next slide, please. So far, as of November, we now have 2,000 tracers, 22 tracers per 100,000. To give you a sense of gestalt, before the pandemic, the entire country in the United States had about 2,000 tracers. Next slide, please. Some key research highlights. Very early in this pandemic, we created the Rutgers Center for COVID-19 Response and Pandemic Preparedness as a catalyst for growing significant COVID research at Rutgers. A lot of research obviously is still at a very early stage as we still understand this disease. As studies progress, they'll provide further critical platforms. We have many clinical trials underway, a healthcare cohort study, the first and largest for a while at least, a health practitioner cohort study underway as well. Next slide, please. Key test accomplishments vis-a-vis testing. The RUCDR developed high throughput testing, maybe the largest for a single site. At that point, it was 20,000 a day. It's now up to 50,000 a day for a single site. And again, there are multiple sites that have now been established. Development and evaluation of saliva for viral testing, first to obtain approval in the US. They're now far along in the development of a saliva test, which will test both COVID and influenza A and influenza B in the same testing. And development of testing of the first point of care test with the results in 45 minutes that was commercialized by Cepheid. That came out of New Jersey Medical School, as I had mentioned. Next slide, please. Our Rutgers technology underlies Abbott's 15-minute test. We have an antibody test being developed, now being validated in our healthcare workers study, and a validation study underway for Beckman Coulter of a widely used sample processing system for applicability as a front end for COVID-19 diagnostics. Next slide, please. Lots of clinical trials are underway, including evaluations of remdesivir, dexamethasone, convalescent plasma, among multiple other things as well. Next slide, please. The COVID-19, the center that was established, funded jointly by us, by David Kimball at ORED, and by Rutgers New Brunswick, was stood up incredibly quickly, gave pilot data from multiple grants. As you can see there, we ended up awarding biomedical research 23 awards for 97 applications, social science 13 applications, 13 grants for 61 applications. It has already resulted in tens of millions of dollars in NIH funding to follow it. Next slide, please. COVID vaccine study, the Moderna vaccine was tested by Newark, focusing on a minority population. And that enrollment has finished. The J&J vaccine is enrolling now statewide, focusing on healthcare workers, employees, alumni, community cohort, and incarcerated populations. And And now the Sanofi vaccine we were just approved for. So the infrastructure set up in Newark for the Moderna vaccine will be used now for the Sanofi vaccine as well. Next slide, please. This gives you the trailers set up in our Piscataway campus, which doubles as space for the J&J vaccine trials. Next slide, please. Shows you a mobile health clinic, a van funded by NIH for use for vaccine trials. Next slide. Lots of diagnostic research underway. I won't go through in detail. RNA testing, antigen testing, antibody testing. I mentioned a few of them. Next slide. We have a new COVID-19 serology testing facility that we put in place. Next slide. And finally, lots of studies are underway also looking at a SARS-CoV-2 mitigation in air and on surfaces. How do you kill it? In airplanes, in subways, in prisons. How do we prevent the spread by coming up with new creative ways of decontaminating surfaces? Next slide. So with that, I'd like to stop, and I gather questions will come after the next speaker. Thank you.
Hey, thank you very much, Brian. That was really informative and insightful. We're going to travel now to Tel Aviv, where Dan Pierre will introduce the next speaker.
Okay, so thank you so much for this really enlightening presentation. Our next speaker is Dr. Dan Yamin. He's the head of the Laboratory for Epidemic Modeling and Analysis at the Faculty of Engineering here at Tel Aviv University. And Dan is also on the board of director of our newly established Center for Combating Pandemics at Tel Aviv University. So Dan, please share with us your presentation.
Thank you very much for the warm introduction, and thanks for inviting me. First and foremost, I'm an engineer, and my background is an engineer, but I have an extension background in epidemiology from the School of Public Health at Yale University. And 5 years ago, I founded the Laboratory for Epidemic Modeling and Analysis at Tel Aviv University with the goal of harnessing the power of big data to defeat epidemics. So in this upcoming 20 minutes talk, I will briefly discuss about our COVID-related projects in the lab. And then I will highlight and expand on a specific project. And in the remaining time, I will discuss about my personal experience with policymakers in Israel. So I will present the related projects in accordance with the disease progression of COVID. So first, exposed individuals get into their incubation period where they show no symptoms. And then later on, part of them show early symptoms that are typically mild, and a fraction of them will feel that they would like to check and test and report their symptoms. Some of them will eventually have severe outcomes, and that is the greatest problem, the hospitalization and death. And this is our first project where we try by utilizing highly detailed data from hospitals to predict who is going to have a deterioration. But understanding that that might be too late, we also wanted to focus on an additional project where we try to predict for individuals that ask to become tested if it is going to turn out into a COVID infection. And interestingly, we can get a pretty good results. Now it's, my student just informed me they got into an ROC of almost 90% because of three interesting aspects. The first would be the environment. So the environment of the individual, his family, what we can see in the specific region. The second is the symptoms that he show during this meeting. And the third, non less important, is his electronic medical records. So the electronic medical records provide us a very great opportunity not only to understand the medical records, for so to speak, and explore them, but also to get some aspects about the behavior of the individuals. And indeed, we can see that a very good marker of who is going to be eventually found to be tested positive is an individual that got vaccination for flu, for example, or individuals that tend to take more medications than others. So it's a combination of factors. Some of them are medical, some of them are predictors that are related to the behavioral aspects. But as I said, most individuals do not ask to be tested. And therefore, we wanted to ask if we can maybe contribute earlier in the disease framework. And for that, we would like to utilize our number one addictions, and that's our phone. We're going to conduct basically a clinical trial where we are going to track 5,000 participants for 2 years, and we will provide them a mobile application, or basically they will be asked to download an application that is a designated application that collects data passively and actively. And ideally, we'd like to see if we can improve diagnosis by seeing not only one point in time, but also analyze in a dynamic fashion the deterioration, symptoms, and some interesting conditions that are related to the activity levels of the individuals. But we try to ask ourselves, can we even go a little bit earlier to what is called the incubation period? And this is our fourth project, where we try to equip these 5,000 individuals with wearables, with smartwatches that provides us an interesting and fascinating information about other aspects that some of them are clinical. So I'll be more clear in that. Typically, we said that there is an incubation period, but in fact, we can say that there is a digital symptoms, and they are clinical symptoms that an individual might not see them. They are invisible. For example, some changes in sleeping habits, some changes in the heartbeat that can be useful for early detection of COVID. And thanks to my previous colleague, you can understand what is the importance of early detection. But we ask ourselves another question. Can we go even back earlier and ask a pretty ambitious question before the individual even got infected? Can we identify hotspots? Can we identify what regions are at elevated risk in order to develop control strategies? And that's going to be the main focus of today's talk. So if you like, what you basically try to do in all of these projects is to develop a data scope where we utilize medical and non-medical data that takes into consideration the patient, the individual patient himself, but also population level aspects in order to improve our understanding and to early detect COVID-19. So moving to our specific project that I'll discuss today is identify hotspots to develop control strategies. So this is the data that we use for that project. We're talking about mobility records based on cellular data of over 3 million users from one of the largest telecommunication companies in Israel. And it's very important for me to denote that it is in accordance with the GDPR guidelines. The data is aggregated and anonymized, and there is no possibility to identify the individual. It specifies the mobility pattern within and between 2,630 zones covering Israel on an hourly basis. And we try to ask ourselves, well, it's aggregated. Can we really learn from aggregated data? So I would argue that we can learn quite a lot. This is just a simple, This is just a simple demonstration of what we can see. This is a specific zone in Israel, Mount Meron. There's nothing interesting there on a daily basis, with the exception of what you can see here in dashed on the 11th. That is where we have Lag BaOmer, and it is customary for religious groups to come and visit the mountain. However, due to COVID, it was blocked. So they just waited. They waited for 2 days until it was opened, and then we could see this spike here, and then we can tell to what regions they typically go. And then boom, you can identify hotspots. So that's in a nutshell what we can achieve from aggregated data in a way that is not invasive to the individual. This is another demonstration. You can basically learn about or get the big picture of how things happen in Israel. This is the normal basis here. It's average, basically on a weekly basis. It's a week window of the percentage reduction compared to the baseline. That is where we had in Israel the first lockdown. And obviously it mainly affected long distances. And we could see a substantial reduction that had no parallel in the past. Then we can see gradually a change, an increase, a spike, and then eventually you can see here the holiday. This is school break. This is just before we start school, so everybody wants to go for vacations, and then boom, again, we got into the second lockdown in Israel. Now, okay, so we can, I hope I succeeded to convince you that we can understand or get some good understanding about mobility. But what about transmission? So this is the effective reproductive ratio, okay, the R naught or R effective, we should say. And here on the x-axis, you can see the mobility, okay? And this graph is provided in a lag of 10 days. So first we can see changes in mobility. 10 days after, we could see what was the measured R effective. And well, I should say, this is correlation, okay? We have to be very careful when we talk about correlations, but it provides a very interesting understanding on a global, on a national scale. Interestingly, I should say that when we see about 75% mobility compared to baseline, that is where the R exceeds 1. That's what we saw in Israel 7 days ago. So we'll see how it goes. It was very important for us to provide policymakers not only our results and assessments, but also to give them a tool. So we developed a tool that they can actually play with some values related to the epidemiological aspect that I will show soon, but also the mobility patterns, where we can actually rank some cities in terms of mobility, identify some interesting mobility patterns that are related to date and to specific days. So this is how it looks like. And by working quite a lot and trying to understand what is that tool that we obtained, we found out that, or what I typically like to call the supermarket effect. This supermarket effect is that either you're going to meet the same person 5 times in the market where you go there, or you don't see him at all. So, you know, in Israel, we say everybody are friends of each other, Kol Israel Chaverim, but when it comes to visiting patterns, I would argue that it's not really the case. We can see that the Arab population, for example, mainly congregate with each other. The Jewish Orthodox mainly congregate with each other. And this is far beyond the geographical locations. So this is one thing. Another thing we did some slicing related to socioeconomic statuses. And obviously we can have a better focus granularity. So that basically gave us a better understanding that the mobility varies considerably, and we can basically look at Israel and slice it into several heterogeneous patterns. What does it mean about transmission? So that's what you can see related to transmission. This is the time. It started as a disease of low, middle, and high socioeconomic statuses evenly. But soon, because of many reasons that I will be happy to discuss later, it became a main concern for individuals with low socioeconomic status. And unfortunately, that is the case today as well. When we checked on a regional level, again, we obtained this very interesting pattern that mobility with 10 days or 12 days can capture transmission. And this is the mobility pattern. We integrated these mobile data with an epidemiological model. Individuals in our model can be either susceptible to become infectious or exposed, or infectious and exposed. That is a very unique condition of this disease, where individuals may not show symptoms and still transmit. And then part of them are reported, part are unreported until recovery. So this is our model. And with only 5 parameters, we could pretty nicely capture the spatio-temporal dynamics of this disease and the age-related structure of the disease, just with 5 parameters, by accounting explicitly for the aggregated mobility patterns. We then used this model to ask some questions. We used optimal control theory in order to say, to ask some policy-related question. Specifically, we understand that hospital overwhelm is something we definitely don't want to reach to. And then the question is, how can we ensure that we're not reaching to hospital overwhelm, and then check some specific strategies related to lockdowns and some prioritizations of populations, for example, school closure and others. And I will just summarize the results. So the first question we ask is, what is more effective to reduce severe outcomes of COVID in Israel? Local lockdowns or global lockdowns? And the answer was by far local lockdowns. And then we ask, okay, that is when we talk about effectiveness, but maybe it is not efficient. And when I say efficient, I mean the number of individuals that will have to stay at home per benefit. So again, by using this model, we ensured that we will never reach to a situation where we exceed the hospital capacity. And the answer is that local lockdowns are not only more effective, but also more efficient. Then we asked, okay, so what should we do with respect to schools? Should we close schools or open schools? We checked various assumptions, and the bottom line was that if we want to reduce severe outcomes, we should open schools. And this is not only because of what always people are talking about, which is herd protection. No, not at all. It's not a 0-1 game. The moment an individual, first we have to do all of we can that individuals are not going to be infected. But if somebody is getting infected and then moved to a recovered compartment, that basically means that the disease is now weaker. There is lower transmission. And that is why we obtained that school opening would be better than school closure in terms of severe outcomes. Not only effective, but also efficient. And then we checked to see what was conducted in Israel. What did policymakers did? And I would say the exact opposite, okay? And I try to ask myself, how come they didn't listen to us? And I should say that, I worked constantly with policymakers in Israel, and unfortunately, we could help them in many manners to identify hotspots. even to put it to prioritize and recommend on places where they should put testing spots. But when it comes to the global picture, when it comes to lockdowns, our recommendations were not adopted. And I have to say honestly that it's hard to tell why and what is the reason, but it could be, and that's what I claim, it could be that it is related to their goal. And I talked about the goal of minimizing the number of casualties, but we can see that there is a very high correlation in various developed countries between the number of infected individuals, not severe outcomes, infected, and how grateful or thankful, what is the opinion of the public from the functioning of the government. And because of that, I believe that sometimes when politics come into place, we have to think about larger pictures, not about what is right, and sometimes what is perceived right. So this is basically the way I see it, but obviously there may be many other reasons. I'd like to thank the team and collaborators for those projects. And I think there is a great opportunity here, and I'll be very grateful to collaborate with colleagues from Rutgers University. Israel has similar characteristic, even in the size, not only the population size, but the areas. There are much of similarity. So I'll be thankful to collaborate with you guys. Thank you very much.
Thank you for that really fascinating presentation. Let's go to Dan Peer in Israel, and you will lead a discussion about the questions that have come in. And any questions, please make sure you submit them so that we can get at them. Thank you.
Okay, thank you, David. So we got really a lot of questions. I'll start one by one, and both Dan and Brian, feel free to answer. The first one is really up to date. So what is your understanding of the announcement today from Pfizer that their vaccine has a 90% effective rate? And this is from Charles Small.
So I can fairly say I don't have any inside knowledge, but I can describe, so I can be free to answer. I think everybody has probably seen the announcement. Pfizer designed its protocol differently than other vaccine companies. The FDA is requiring for a vaccine to be effective that it be 50% effective as their threshold. Pfizer began its trials later and designed it with multiple looks at the data with a 90% assumption of efficacy. So it would take additional looks, more of the p-value for those who understand the statistics would be expended at these multiple looks. And it felt it could do that and was willing to do that because it was betting on a 90% efficacy instead of a 50% efficacy. And as far as I can see in the news, and again, I don't have any inside knowledge about it, it looks like it paid off. That the first time they looked, it looks like it is triggering. Now, they benefited obviously from the fact that the pandemic has come back. And so they have a lot of additional cases. From a mechanistic point of view, it's the same type of vaccine as the Moderna vaccine. So it does argue that if it works, the Moderna vaccine, which started earlier, should be working as well. This is obviously hot off the press data, and they first look at very small numbers. So that almost all of their positives that they're seeing at that first look are in the placebo group instead of in the active group. That will change as they look over time. But certainly it's very encouraging that a vaccine will be protective. We don't know how long the protection will last, and that the approach that was used by them and by Moderna will in fact be effective. So it's exciting news.
Okay, we have another question for you, Brian. It's from Samuel Yerushalmi, who basically I want to ask about the connection between so quick and the biggest spread of COVID-19 around the world to missing of equal and enough developed public healthcare services in majorities of countries.
Sorry, I'm not sure I understand the question.
Good question. Yeah, I think we'll go to the next round and then try to explain it again. So the next one is, since this virus has acted differently than previous coronavirus-based pandemics, how can we modify our scientific and medical approaches to stem the virulence and spread of this disease? Should we be developing novel detection methods, novel neutralization methods?
Yeah, I think the simple answer is yes. Obviously, I think the differences compared to other coronaviruses and other viruses, flu and otherwise, this is both more, has worse outcomes, it's more serious than something like the flu, compared to cold, URI type coronaviruses. It's clearly worse outcomes compared to others like SARS, MERS, and so on. It's a respiratory virus. So that means it can spread as easily as the flu or even more easily, but having bad outcomes. I think, yes, we absolutely need to be putting in place multiple different mechanisms. Unfortunately, in the US, in recent years, we took down our protections from a public health point of view, both in the US and what CDC used to do in a lot of other countries. We need more monitoring in other countries. We need, as well as in the US, we need more public health infrastructure, so when these kind of things happen, they can be jumped on. This didn't have to be the pandemic that it is, especially in the US. It was clear, as I alluded to in my data, it was clear to us in January what was going to happen in the US. And yet we were completely unprepared for it. We did not use the extra months that we had between then as a country to prepare, whether from a PPE point of view, whether from a public health point of view. We completely wasted that time. And as a world, and from a WHO, and obviously our government pulled support out of WHO instead of supporting WHO even more, talking about policy issues. As a world, what we really need to do for future pandemics to address them is clearly expand public health, expand what is being done throughout the world to try to detect new diseases and have more infrastructure. I mean, the fact that we now have 2,000 tracers in New Jersey and the entire US, and this is now November, the entire US only had 2,000 tracers as recently as mid to late spring, is preposterous how unprepared we were as a country, and with that spreading it around the country and around the world.
Okay, Dan, I want to ask you basically the same question from your perspective in Israel.
So from my perspective, I'd like to say that, yes, when we look at COVID in general, we can say this is a very deadly disease. But when we compare to flu, and we have to make this distinction, when it comes to children, flu is way more deadly. Flu has way more complication in children. And that is the challenge, and that's what makes this disease so deadly. The fact that in most cases, it's mild, it's even asymptomatic. And that's why I think in order to try to do our best to deal with that tricky disease, we have to understand that the behavior of the individuals is the major aspect. And we have to try to speak to the individuals the way they understand. And I think that would be pivotal for detection and to detect, to isolate, and to contain the disease as much as we can. I'd also like to note, there are a lot of talk about the long COVID effect. And it's true, we still don't know about this long COVID effect. But we can know for sure that there is a very long COVID effect from lockdowns. There is a very long COVID effect when we close schools. We can see depressions. We can see individuals that do not seek for care from other diseases. We see that we have weaknesses in preventative medicine that ultimately lead to death. And that's why, you know, we always have to balance between the problem, which is a great concern, of COVID, and the problems that are related to the way we intervene.
Okay, so back to you. Actually, Dan, I'm going to ask you another question. Lockdown in Israel was seriously effective in reducing the incidence. Can you please review this data?
Okay, so it is true that when you have a massive effect, then you have you reduce substantially the transmission. That is clear. However, we can see now in Israel. So we had a very long 1 month lockdown. Okay, I was asked by public health officials, and I said 2 weeks lockdown is not going to, the way you plan to do is not going to be useful in reducing transmission. And eventually they reached to 1 month, okay, 1 month of a lockdown. And now we return gradually to a spike. And then the question is, what happened in this 1 month? I can tell you from our pilot study that at least those who participate in our study suffer from so many aspects. You know, their sleeping habits has changed, their mood has changed, they consume more medications. So we have to take into account the larger picture. And so it's true. A global lockdown will eventually lead to a sharp decline in transmission. But when you ask about effectiveness and efficiency, it would be way more effective to try to tackle regions that have high cases and specifically protect those at high risk. Because as I said, the challenge of this disease is the fact that it is so much not deadly in children and so much deadly in elderly.
Just a couple of follow-ups, and I found Dan's data fascinating and interesting that way. To the degree that you look at the U.S. and the heterogeneity in the U.S. as sort of an experiment as well, we had a very large effective lockdown in the Northeast in the spring when we were the epicenter of the world, and got to a much lower level in the process. So it put us in a good position to be able to address with containment, usual case identification and quarantine in a way that you can't do it when in fact the number of cases are too large. That's where a lockdown makes sense. It makes much less sense when you're now on the way up. When you're now on the way up, what you want to do is, hopefully with more capacity for detection and tracing and quarantine, so you can contain much better, you can be more localized. And in fact, at least the experience in New Jersey so far has been exactly that. It has been more surgical in the second wave rather than more of a general lockdown. There were the two first blips that occurred as part of the second wave. One was an area in New Jersey called Ocean County, where there were a lot of religious Jews who were connected to the New York epidemic, and the other was at Rutgers. And I showed you the data in terms of our second blip in terms of students and behavior. Dan's comment about behavior and the importance of behavior. So there were surgical interventions in both cases, not surgical meaning cutting things out, obviously, but surgical in terms of trying to change behavior in those areas. And they were successful in bringing the rates down accordingly. We have the advantage of starting at much lower rates than the rest of the country because our general lockdown was successful. But the goal is to avoid a second general lockdown if we possibly can. Take advantage of the fact that we're low to begin with. And so even an exponential increase is not nearly as large an increase over time, and use surgical approaches instead of general.
I totally agree. If I may say, you know, in Israel, we see now a phenomena where in specific regions, so people don't want to be tested. So the government says, okay, it still means that you are a red zone. because we see that there is a very high proportion positive, as Brian suggested in his talk. Now, interestingly, so they decided, okay, we don't want to be a red region. So they ask people that feel good to be tested and ask those that don't not to become tested. And here, that is the main problem. And that is also the main way for solution, to try to talk with the people and try to communicate and do things that are important from their perception.
Okay, so Dan and Brian, there are lots of questions, but I think some of the question relates to the fact that there's schools closure. So I think if I can summarize a few questions into one, I would say, can the rationale be explained again for why schools closure would decrease severe COVID cases? But there are a few others related to the same topic.
Yes, so I will discuss, but I didn't say it's going to reduce COVID cases. I said it will reduce severe cases. Now, okay, so most of the studies suggest that children have lower chance to become infected. Others said that they equally get infected, but their symptoms are so mild or unnoticeable. But it's clear that once they are infected, we should ask who they will infect. And they will infect, I'm talking about young children, to the most part, they will infect their young family, and eventually it's not going to be a great concern for most of them. Now, in the current situation where we have people using face masks, when we have those social distancing, they are effective in Israel, ranges between 1 to 1.3. Okay, that basically means that we are in an epidemic, but we're not in a part when, like measles 11, that it is not, or even 3, the corona before the restrictions. And because of that, it is likely that children will either not infect or will infect their relatives that are young. Okay, so this is basically in terms of severe outcomes. Now we have to keep in mind, if somebody got infected and recovered, so now the overall transmission dynamics is weaker. So you have fewer individuals that can become infected, and that is not the herd protection, but it is somewhere in between that basically suggests that there is a limited effect to children that are getting infected, and that is more or less in a nutshell, the main reason why we obtained our results from the model.
Okay, Brian.
Yeah, I think that's fascinating. I think in New Jersey, people took a different approach. I think schools were shut down early on. Of course, early on, we were so terrible. And then after that, there never was a clear political decision, open or closed. So it has been, they've left it up to local school systems, and different local school systems are making different decisions. And what we find is the schools that opened, when they then get a case, shut down. And so more and more of the schools are now beginning to shut down as cases come back. I do think universities are different. I mean, I find Dan's logic very compelling for schools, undergraduate, for younger schools. I think universities are different because it's driven really by bad behavior. Bad is the wrong word, from of our students. The point is, when kids go and party in bars, not wearing masks, not social distancing, none of that's being done, they spread it accordingly, and they spread it among each other. They will spread it to the faculty, they'll spread it. And in fact, one of the issues, even with primary and secondary school, is in New Jersey, we have a very unionized environment, and school teachers didn't want the schools to be open. The teachers' unions protested. And same issue among our faculty, not wanting to come back when the students are, if safety can't be assured, which we can't. And that's especially the case, even the football team, we couldn't keep protected in their bubble from getting contaminated. And so little kids you have more control over behavior-wise, and their parents, hopefully. And in many ways, it comes back to Dan's comment about the real issue is behavior. And the initial question that was asked by one of the questioners, or what would you do differently anticipating later pandemics, is really if the public trusted science more and public health more, and if our government encouraged that, hopefully behavior would be better. And with behavior being better, you wouldn't need as drastic a shutdown in order to be able to stop the spread.
So guys, I want to ask you, I think the last questions, because we are running out of time, although we have so many other questions. So a question for both of you. What explains the large cross-country differences in mortality rates?
Dan, you want to start, or?
Yeah, so I think it's really interesting because I would like to share my personal view. About 7 months ago, I'm in the Faculty of Engineering. That's what we do, analyze data. And it was clear to me that the chances to die are way below 1%. And I explained in an article why it is. And I even mentioned there that, I said, I quote, what is the absurd? The absurd is that the WHO, as far as we can see, is wrong, and the chances to die is not 4% to 7%. And the absurd is that Trump, that said is below 1%, was right. Now, the editor said, okay, that's going to be the title, without asking me. And in a second, Trump retweeted this article, and I became an enemy of all Democrats in the US, and the vice versa with respect to the Republicans, and my bell box was shut. And I asked, like, how could that be? I mean, and that gave me a lesson about virality. I think the bottom line is this: there is a very high differentiation between different age groups, and that is part of the reasons. And Israel is the country with high fertility and younger age population size compared to developed countries. This is one thing. Second, the more you test, the more you find. We know that in most countries, most cases are unreported. So this is another thing that lead to some differences. And the third is the ability of the country to protect those at high risk. So just to give some sense, we're talking about more than 60% of those who die are above, at least in Israel, are above the age of 80. And 90% of those who die are population at high risk, okay? So that's what makes different approaches to different case fatalities worldwide. That's the way I see it.
Yeah, so my answer is analogous, but slightly different. I think it's important to differentiate when you talk about differences in mortality rate, whether you're talking about mortality rate or case fatality rate, because they're different. Mortality rate is how many people are dying in the population divided by total population. Case fatality rate is of everybody who gets the disease, what proportion die. And they are very much interacting here in the impact. And the case fatality rate, I think, is hard to know the reality. And for the reasons that Dan was talking about, I think there are huge numbers of cases aren't being detected because people aren't doing testing, and the penetration of testing is dramatically different. And again, keeping in mind, 40% of people asymptomatic, another 40% have mild symptoms and often never get diagnosed. So you're talking about, if you're missing 80% or 90% of cases, your case fatality rate can be twice or lower. Huge differences in testing. Huge differences also though in evolution of the epidemic, of the pandemic. That, Trump is sitting there going, oh, now we're doing much better because the disease has gone, our case fatality rate has gone away. That's because we wait a few weeks. That'll change because there's a lag, as I talked about before. You get the disease, 2 weeks later you get hospitalizations, 2 weeks later you get the deaths. So the deaths are just beginning. And in fact, across the US, they're in different the case fatality rate is different in different parts of the US because the evolution of the pandemic. But the other difference in disparities, our country has enormous inequities. And yes, elderly and people with underlying illness are clearly at higher risk, but so are poor populations, minority populations, and other populations who are at higher risk of getting the disease. They're at higher risk of suffering bad outcomes when they get the disease. Some of this is their underlying condition, more diabetes, more hypertension, untreated conditions, and so on. Some of it is access to medical care. We have without a national health system, we have very unequal access to medical care. Of course, so those are big differences across the world. There are even big differences across the US as well, which lead to large differences in case fatality rate. I don't think we know yet what the real case fatality rate is here because the numbers don't make sense. We don't have the correct denominators, as Dan was talking about, in order to be able to know what it really is. Is it more like the flu? Maybe. Is it 10 times the flu? Maybe. Is it 20 or 30 times the flu? But clearly it differs by age as well. And I think Dan's comment about different age distributions in different countries makes a massive difference as well.
Okay, guys, I think that I want to apologize for all the other questions that we had, but it's a very vibrant area. And I want to thank you both for giving a fantastic presentation and being the first in this joint symposium. I want to thank also David, who really did a great job behind the scenes and in front of the scenes as well. And I think that we will meet again in about a month in December 14 for our next two speakers, one from Tel Aviv University, the other one from Rutgers, that will talk about drug discovery there. So thank you again. And David, you want to say a few more words?
I just want to say I look forward to seeing all of you in another month on the 14th of December. And this has been a fabulous set of presentations and great questions, really topical. I look forward to this continuing and to building on our scientific collaboration. So thank you so much.